This afternoon, I'll be taking you through practical tips on the use of intravenous iron for the treatment of anemia in pregnancy. I don't need to introduce myself. That has already been done in the citation. By way of introduction, anemia is defined according to the World Health Organization criteria as hemoglobin concentration less than 12 grams per deciliter in the non-pregnant women. And in pregnancy, it is defined as hemoglobin concentration less than 11 grams per deciliter in the first or third trimester of pregnancy, or less than 10 grams per deciliter in the second trimester. It is a public health burden globally because the prevalence exceeds 5% in most regions of the world. Specifically, the global prevalence of anemia in pregnancy is 36.5%, according to World Health Organization report of 2023. The prevalence is highest in sub-Saharan African regions and Southeast Asia, where the prevalence exceeds 40%. According to the Demographic Health Survey of 2018, the prevalence of anemia in pregnancy was found to be 61.1%. As obstetricians and gynecologists on this platform, we are aware that if this condition is not promptly identified and treated, it can result in an array of complications ranging from preterm delivery, increase in the incidence of intrauterine growth restriction, or outright fetal deaths in utero. Recently, research has found that there is an association between mental health disorders like anxiety and depression and the risk of, between anemia and the risk of mental health disorders like anxiety and depression. Now, there are many causes of anemia. Amongst these are infections like malaria, infestations like hookworm infestation, hemorrhage from various causes like antepartum hemorrhage, postpartum hemorrhage in obstetrics. It can also be due to underlying hemoglobinopathies like sickle cell disorder and thalassemias. And it can be due to nutritional deficiencies. Frankly speaking, nutritional deficiencies still remains the commonest cause. And amongst these nutritional factors that can cause anemia, like iron deficiency, vitamin B12 deficiency, iron deficiency has been found to be the commonest cause. In a study which we extracted from the HIVON trial, I won't go into defining what HIVON trial is because I know we've presented HIVON trial previously on this platform, and most of us actually conversant with the acronym, which only stands for intravenous versus oral iron for treatment of iron deficiency anemia and pregnancy in Nigeria. So we found that 41% of pregnant women, we found that 41% of pregnant women with moderate or severe anemia had iron deficiency. The range from a systematic review by Ugu et al. Was 25 to 46% in Nigeria. That's for iron deficiency amongst anemic pregnant women. Now, coming to the treatment proper, which will be the main topic for today, WHO has recommended iron supplementation both for prophylaxis and treatment of anemia in pregnancy. For prophylaxis, the current recommendation is that 30 to 60 milligrams of elemental iron should be given daily through pregnancy. But higher doses is actually recommended in those settings where the disease burden is severe. In public health, when we talk about severe public conditions that are severe public health burden, we mean conditions which prevalence exceeds 40%. So for this reason, this recommendation is targeted at low middle income countries in sub-Saharan Africa and Southeast Asia, as previously discussed. Then 120 milligrams elemental iron is recommended weekly in places with mild burden. Places with mild burden refers to countries where the prevalence of anemia in pregnancy is between 5 and 20%. So we have places like most part of Europe and the Americas. For treatment, it is elemental iron should be given daily, and this should be continued until the hemoglobin concentration normalizes. When it normalizes, then we can tail down to prophylactic dose. Supplemental iron can be given through 3 major routes: orally, which we all are conversant with, can be given intramuscularly or intravenously. So the main topic for today will be on the use of intravenous iron, that's administering it through this route. Then blood transfusion oftentimes is reserved for severe cases of anemia. That's when the hemoglobin concentration is less than 7 grams per deciliter, or when pregnancy is already advanced and the woman is approaching term. We are talking about from like 36 weeks onward. If the patient is already having symptoms of anemia like weakness, dizziness, palpitation, fainting spells, then blood transfusion might be indicated. Or if there is an ongoing hemorrhage, then there will be a need for blood replacement. There is none of these treatment modalities I've mentioned that is not fraught with its own challenge. So I will go through this one by one. I'm deliberately emphasizing on these theoretical concepts so that when we come to the practical steps of administration, we'll be able to understand clearly why what should be what and why we should do things a certain way. For oral iron, a major problem is the high incidence of side effects compared to the parenteral formulations. Side effects, basically gastrointestinal in form of nausea, vomiting, diarrhea, or even constipation in some cases, which can be worrisome to the patient. So this might actually result in poor adherence to the use of these drugs. And yes, it's been found in a previous study that quite a sizable proportion of women will still progress in a state of anemia even into delivery despite iron supplementation. So the question is, were they really taking this oral iron, or was it insufficient to combat the problem? Then limited duodenal absorption is another problem. And you are all aware this is a reason why oftentimes I want to prescribe vitamin C alongside to facilitate absorption. Because without the influence of vitamin C, only about 10% of the iron will be absorbed and be available for use. Then the long course of the therapy. When we put our women on oral iron for treatment, they have to continue taking it over time before we can observe meaningful effects. And that effect oftentimes anyway will be evident if the underlying cause is iron deficiency, otherwise it might not be beneficial. Then for intravenous iron, having to administer this medication is invasive. So coupled with the fact that manpower is needed to perform such invasive procedures, so that might be the reason why the use is not so popular in many facilities. Then cost is another problem, as we are generally speaking, even iron dextran, which is apparently the cheapest of the iron formulation we know, is still costlier than oral iron. Then side effects of the medication, the most worrisome of which is anaphylactic reaction, and which is a major reason why most skilled healthcare providers tend to be shying away from the use of intravenous iron. We'll talk more about this as we go, because fortunately we now have safer and effective alternatives. Coming to anaphylactic reaction, the worry is actually more with the use of iron dextran, specifically the high molecular weight iron dextran, not the low molecular weight dextrans. Although both can cause anaphylactic reaction, generally speaking, the incidence of anaphylactic reaction with the use of iron dextran has been reported to be between 0.6 to 2.3% in most studies. Whereas iron sucrose, which can also be given intravenously, has a much lower incidence of anaphylactic reaction of 0.002%. That's only about 2 out of 1,000 people may have anaphylactic reaction. But for ferrigluconate, the incidence is about 0.04%. So coming to intramuscular iron, when we administer iron through this route, it's difficult for us to give total dose iron because you can't put the whole lot into the gluteal muscle at a go. It has to be given in bits over time. So there is need for repeat dosing. Secondly, these medications are often associated with pain when injected intramuscularly. Then incomplete absorption can be a problem. A study found that it takes about 72 hours for iron to be absorbed when given intramuscularly. At least you need 72 hours to have elapsed for significant proportion. The majority of it will have been absorbed. And there will still be some residual iron left intramuscularly, which will now be gradually absorbed over time, and it might take up to 28 more days for everything to be absorbed, or at least near completion. Then the side effects of the drugs, which includes higher incidence of gluteal abscess, and of course, depending on the skill of the person injecting, other damages can even occur, like damage to the sciatic nerve. Then there might be other complications like lymphadenopathy with its use. For blood transfusion, the main worry is transfusion reaction, which includes starting from the milder ones like urticaria, fever with chills, then to more severe ones like acute hemolysis, which can be massive, resulting in hemoglobinuria. Before we go into the use of oral iron itself, I want to bring to your knowledge here what the current practice in Nigeria is, because we conducted a survey recently at 84 health facilities operating at primary, secondary, and tertiary health level in Lagos and Kano State, and these were our findings. I am presenting this deliberately because I think we need to know so that we'll be able to make informed decisions when we need to treat our patients. On the usage of iron supplements, we found that 96.9% of our skilled health providers will give oral iron for treatment. And the oral iron most commonly uses ferrous sulfate by 36% of them, ferrous fumarate by 22%, while approximately 21% will use ferrous gluconate. We know that these drugs actually, the constituent of elemental iron in them differ. One interesting finding from this particular study is that we realized that 57.3% of the skilled healthcare providers who prescribe oral ferrous sulfate would give at doses that exceed the World Health Organization recommendation of 120 milligrams daily for treatment, while the only 4% of them will prescribe gluconate at doses exceeding WHO recommended dose. The only take-home message from this is that it seems as if our skilled health providers do not take into consideration the constituent of elemental iron in these drugs when they are prescribing. So to enlighten us on what should be so that we can give our patients appropriate dosing, considering that there is also a possibility that some skilled health providers might actually be prescribing Invu underdose. And that might actually explain why they might not even achieve significant response. For ferrous gluconate, which often you will see 210 milligrams per tablet written on, the amount of elemental iron in it is 65 milligrams. For ferrous gluconate, oftentimes you see us writing Fergon, 300 milligrams. 300 milligrams per tablet, but the amount of elemental iron is just 35 milligrams. Meaning for every tablet you are prescribing, the patient is only going to get, there is only 35 milligrams elemental iron inside. For ferrous sulfate, 200 milligrams, the amount of elemental iron it contains is 65 milligrams. Then for ferrous ferritin, which is in form of syrup, 190 milligrams per 5 ml. That 5 ml contains just 27.9 milligrams. I want to believe that this will be helpful for us in our practice. Now, talking about the parenteral preparation, we realize that only 30% of our skilled health providers has ever in their practice prescribed intravenous iron, whereas only 10% has ever prescribed intramuscular iron. This just to show you how much, to what extent our skilled health providers shy away with the use of intravenous iron despite some of its benefits. Then on the type of parenteral iron being used, 69% of them, of those who has ever prescribed parenteral iron had prescribed iron dextran, while approximately 32% had prescribed iron sucrose. We inquired from them what their perceived disadvantage for the use of intravenous iron is, and we realized that 40% of them think it is too expensive. Approximately another 40% think, oh, the need for venipuncture and possibly need for human resources are some of the factors that hamper its use. Safety, surprisingly, was not an issue of much concern because only 6% of the skilled healthcare providers reported that. Now, on the perceived advantage of using intravenous iron, yes, 47% of them agreed that it brings about faster improvement and that it will be relevant when there is need for faster correction, especially in late pregnancy. While 31% of them feel is beneficial when oral iron has failed. And only 2% of them said it might be preferable to most women. Now, regarding the treatment in infection, 52% of the skilled healthcare providers said they will treat with iron preparation when there is an ongoing infection because they think, about 16% of them think the anemia will get worse if not treated. While for those who will not treat, 38% of them is because of the policy in the hospital that they have to refer such cases when the case becomes complex for them. But 37% of the skilled health providers said they won't give because it will favor bacterial growth, which is actually true. Iron in circulation can favor bacterial growth. Now, in terms of what they will prefer to use when there is an ongoing infection, majority favor oral iron and blood transfusion. Very few will think of parenteral iron. Now, let's come to intravenous iron proper and then go through the steps of its administration. Before I proceed, we need to know the history of intravenous iron and how things have evolved over time. The very first iron that came into existence was ferric hydroxide in 1932. Now, this ferric hydroxide was observed to bring about an increment in hemoglobin concentration, and this increment was dependent on the dose given intravenously. However, as they were giving this medication to patients, they realized that there was a high incidence of adverse reactions, including anaphylactic reactions, and this was later linked to the lack of carbohydrate moiety in this drug. That led to the development of iron saccharide in 1947. So with iron saccharide, which contains a carbohydrate moiety, they realized that there was an improvement in the side effect profile. However, it was still not yet optimal. Then in 1954, high molecular weight iron dextran was manufactured. With high molecular weight iron dextran, even though there was a reduction in the incidence of adverse drug event compared to the earlier formulations, it was observed that the incidence of anaphylactic reaction was high. And that was what created fear in most physicians, and many started abandoning its use. Prior to this, papers on the use of intravenous iron had not been published. The very first paper was published in United States in 1980. Then findings led to the development of low molecular weight iron dextran, which was fraught with a lower incidence of anaphylactic reaction compared to the heavy molecular weight. As time progressed, then development of dexferrin, ferrous gluconate for IV use, and iron sucrose came on board in the year 2000. After iron sucrose was found to be more beneficial in terms of the much lower incidence of iron dextran. Until date, it is still quite popular for use in anemia treatment in people who have chronic kidney disease. In 2009, ferromoxitol was manufactured before ferric carboxymaltose and iron isomaltoside came on board. Ferric carboxymaltose, which we'll be talking about subsequently, came on board in 2013 for the first time. So they are no longer in development. They're actually in use in developed countries and a few other countries now. Now, this is just a summary of the adverse drug event profile of 4 different intravenous iron preparation. This iron sucrose, low molecular weight iron dextran, ferromoxitol, and ferric carboxymaltose, which is the newer drug I'll be talking about soon. If you look at the iron reaction from the use of this drug with ferric carboxymaltose, just 1.4%. That is quite good compared to what it is with all these other preparation, even ferromoxitol and iron sucrose, which we think had much lower reaction. Then when it comes to intervention or concomitant medications to be given, like epinephrine, diphenhydramine, phamoxitol, and hydrocortisone, if you look at it, there was no need for them for epinephrine to be given to patients who receive ferric carboxymaltose in this particular study from which I extracted this data. but there was for low molecular weight dextran. Looking at the figures generally, the side effect profile and the need for concomitant medication with the use of ferric carboxymaltose is quite favorable compared to all these other preparations. Now, the HIVON trial provided additional evidence on the use of intravenous ferric carboxymaltose. In terms of the effectiveness, we found from the HIVON trial that the use of intravenous ferric carboxymaltose was associated with a 73% lower risk of having iron deficiency at 36 weeks gestational age. And the risk was 78% lower for iron deficiency anemia, or that's the prevalence actually was 78% lower. Talking about the safety profile, which we found to be similar to that associated with the use of oral ferrous sulfate, which was the comparative drug, the only significant things were found was incidence of asymptomatic hypotension, although the blood pressure wasn't so low as to require any form of intervention. None of the patients needed an intervention for the hypotension, and they all recovered spontaneously within the 1 hour period they were observed in the hospital before leaving. Unfortunately, we cannot really link this to the intravenous ferric carboxymaltose because we did not monitor the blood pressure in those who received oral iron since they received this over a long period. So we can't pick on any particular time point to check their blood pressure for this purpose. It has been shown from previous studies that rapid infusion of IV fluids can be associated with mild hypotension sometimes. So we are even thinking maybe the rapid infusion might be responsible for this and not necessarily the medication itself, because we actually more or less rushed in the fluid at 200 drops per minute. Yeah, it was that fast. So we think it might be responsible. We also observed transient hypophosphatemia, which was significantly higher in those who had intravenous ferric carboxymaltose. But again, this was also asymptomatic because none of the patients had symptoms of hypophosphatemia, which we'll discuss later on. And the good news is that there was no evidence of this hypophosphatemic effect on the fetus, because for the cord blood, the levels were, there was no significant difference in the levels in both arms. But there was a higher incidence of diarrhea in those who used oral iron. Now that we know all this about iron preparations, what are the indications for intravenous iron so that we can carefully select our patient? One is the fact that when we need faster correction, we can consider intravenous iron. In fact, there are some guidelines I stumbled into in which their recommendation when pregnancies are 32 weeks, 32 to 34 weeks, up to 32 to 34 weeks, they recommend that you should just use intravenous iron outright rather than oral iron to bring about that faster correction before pregnancy gets near 10. Then poor response to oral iron. Yes, if you observe that and it is clear that the underlying etiological factor is iron deficiency, then you should consider a switch to intravenous iron. If there is inability of a patient to comply with oral therapy, let's say the patient now tells you, oh, she's such a busy person like Dr. Baba that she will almost always forget to take the iron preparation, then you might just offer that person intravenous iron. In fact, the beauty of it is that in the HIVON trial, issues of adherence was not there because you can give this drug just once, just a single dose, and you achieve good results. When oral iron administration is impossible, for instance, maybe a patient on admission and maybe now having persistent vomiting, persistent protracted vomiting, or for instance, those with multiple gestation, for instance, who keep having hyperemesis gravidarum on and on, you may consider the use of intravenous iron in them, especially if they have crossed the first trimester. Then, if the patient has severe anemia, but this anemia is asymptomatic, you can give intravenous iron. All right, you can always switch to blood transfusion if it becomes symptomatic. We actually enrolled patients with severe anemia in the Ivan trial, and they actually did well. So what are the contraindications? If there is a history of previous allergy to intravenous iron any iron preparation, then you need to, you don't need to use it for such a patient. If there are acute conditions like maybe ongoing hemorrhage or chronic conditions like sickle cell hemoglobinopathies, you don't want to give iron, especially intravenous. If there is liver damage, you also don't want to give, because as we know, the liver plays a significant role in iron metabolism. If pregnancy is not yet up to 13 weeks, it's better to avoid, because the safety profile in terms of embryo toxicity is not conclusive. So that's why we tend to shy away from it in the first trimester. Before we proceed to the administration, I want you to know a few things about two drugs, intravenous ferric carboxymaltose and intravenous iron sucrose. Now, ferric carboxymaltose was approved for the first time in 2013 by the Food Drug Administration UK, that's in the US, that's FDA. And it was not until 2023, that's just 2 years ago, studies found it to be beneficial in adult patients who have heart failure. Before then, none of the intravenous iron preparation was found to be safe for use in heart failure patients, but intravenous ferric carboxymaltose was found to be safe for use in them if they have iron deficiency anemia. And today, it still remains the only iron preparation that is recommended for use in heart failure patients. So this might be beneficial for our pregnant women who have cardiomyopathies. Now, intravenous ferric carboxymaltose was not available in Nigeria before the commencement of the Ivan trial. But following the Ivan trial, I think there is a pharmacy in Lagos that stocks it now. Probably the president will tell us which pharmacy it is. There is a pharmacy in Lagos that stocks it now. Ferric carboxymaltose is a non-dextran iron formulation. That explains why it has a good side effect profile. And the good news is that it's stable in room temperature, provided the temperature is not greater than 30 degrees centigrade. You can store it without refrigerating. But once it is diluted, it has to be used up immediately because it becomes unstable. Now, for iron sucrose, it was first used in Europe in 1949. It was much later in year 2000 that its use became popularized in the USA. It was the drug that replaced iron dextran. So it became popular because it was tested for treatment of anemia in chronic disease patients and was found to be very effective and safe. Until date, in most renal units in Nigeria, iron sucrose, it still remains the most popular intravenous iron supplement. It is syringe stable. By syringe stable, I mean, you can keep it if you have leftover dose, rather than have it, rather than lose it from your vials. You can withdraw it into your syringe and keep it in the syringe like that, maybe in the refrigerator or at room temperature. It is quite stable. Now, before we proceed, we need to learn how to calculate the dose of oral, of this intravenous iron. To calculate the amount of iron needed for replacement, we can do it two ways. We can use the simple, there is no simple approach. We can just like a rough approach. I'll talk about that later. But if you really want to be accurate, use Ganzoni's formula, all right? And according to Ganzoni formula, the amount of iron you'll be given is equal to the body weight of the patient times the iron deficit. Iron deficit is what you want to achieve minus what it is currently, times a factor of 0.24 and the maintenance. So now the factor 0.24 actually came from a multiplication of the iron content in hemoglobin, which was 0.34%, times blood volume. Blood volume is estimated to be 7% of our total body weight, times 1,000, which is just a factor used when you are converting from gram to milligram. Since we are going to arrive at the dose of the total body iron in milligram, units have to balance up. Now, for the iron depot or the tissue iron, to make an allowance for that, if the patient is less than 35 kilograms, we are advised to use 15 milligrams per kilogram to calculate what should be there. But if the patient's weight is 35 kilograms and above, we should just assume it is 500 milligrams. That's what we are going to add to what we get as the deficit at the end of the day to get the total body iron. So this is just an example that if a pregnant woman weighed 81 kilograms and she has hemoglobin concentration of 8 grams per deciliter, the total, if we are to correct this anemia, which is moderate severity, our total body iron will be 81 times. We want to achieve full correction. For a pregnant woman, full correction is 11 grams per deciliter, which is the same thing as 110 grams per liter. So 110 minus 80. Take note that for this particular formula, to calculate the deficit in hemoglobin, use the unit should be in gram per liter, times 0.24, which is our factor or constant, plus 100. And that gave me 1,083 milligrams of iron to be infused in this patient. Now, this is the simplified method I talked about. Maybe you are in a hurry, you don't want to calculate. If the hemoglobin concentration is less than 10 grams per deciliter, and the person's weight is less than 70 kilograms, you can just assume a dose of 1,500 milligrams has been adequate. If that particular patient with moderate or severe anemia weighs up to 70 kilograms and above, then should be given 2,000 milligrams. But if what the person has is mild anemia, hemoglobin concentration of 10 grams per deciliter and above, then you want to give 1,000 milligrams if our weight is below 70 kilograms, or 1,500 milligrams if our weight is up to 70 kilograms and above. Now, for the HIVON trial, now from the Ganzoni formula, you will observe that, yes, there are times if the patient is really, really anemic and the patient is quite weighty, you might even need, sometimes we need doses exceeding 1,000 milligrams. So what the manufacturers of ferric carboxymaltose actually recommended is you can give the first maybe 1,000, maximum 1,000 milligrams first, and you must give an allowance of a minimum 1 week before you now give the additional top-up dose. Or you can divide the doses into 2. You give the first, and a week apart, you give the second portion. For the HIVON trial, because of issues related to drug adherence in our environment, there are patients in the HIVON trial that are enrolled. After enrollment, you don't see them again. They don't even come to the antenatal clinic again. So we thought of, oh, what can we give to our women so that they have maximum benefit, all right, from it. So we made it, like a see and treat kind of thing. We decided to give as single dose, and we use the formula 20 milligrams per kilogram to a maximum of 1,000 milligrams. That's another formula recommended by the manufacturers. All right. So meaning irrespective, if what I've calculated for you is 1,500 milligrams, I will only give you 1,000 milligrams. That's what we did in the clinical trial, and we achieved good results. So this dose, we constituted in 200 mils of normal saline, and we infused over 15 to 20 minutes. Now, Sorghum has a guideline which was not in existence before the commencement of the HIVON trial. There was no guideline on anemia treatment in pregnancy in Nigeria, but it was during the clinical trial they met and they put this together. The Sorghum guideline did not talk about ferric carboxymaltose. It was still being tested now. Now that we know much about ferric carboxymaltose, I think this guideline needs to be updated in several aspects. So they recommended the use of Ganzoni formula to calculate the dose for iron sucrose because that was what was recommended in the Sorghum guideline. And the targeted hemoglobin they recommended to be 11 grams per deciliter. So, but there is one thing I observed in the Sorghum guideline while going through. They did not specify that these doses should be given in bits for iron sucrose because you can't give everything at once. You can only give a maximum of 200 milligrams of iron sucrose at a go. So the recommendation according to the manufacturer is that you give whatever you've calculated, just split into 200 milligrams aliquot, and then you give in bits, but you must spread them apart by minimum 24 hours, not more than 3 doses in a week. So if you are to spread that evenly, I will advise you give a space of minimum 48 to 72 hours before you give the next dose. Now, there are essential tips you must take into consideration. Which weight do you use? You carry your patient's folder, and the nurse has recorded many ways. This patient has been coming to clinic from first trimester, and you are now confused. Am I using today's weight or which weight? If none, pre-pregnancy weight is highly recommended. If you cannot have access to the patient's pre-pregnancy weight, then maybe you look for a weight in the earlier part of a pregnancy, bearing in mind that the weight in later pregnancy has a significant contribution from the developing fetus, the amniotic fluid, and the placenta. So you want to use a weight as early as possible, preferably pre-pregnancy, but as early as possible in pregnancy if that's not available. Now, if a patient is underweight, now, body mass index also play a role in deciding what weight to use. If the patient is underweight, please use whatever weight you have calculated to determine the dosage. But if the patient is obese, you can imagine a patient coming with a weight of 120 kilograms. If we are to apply the formula to calculate, then we might have to be given so much to the patient, and at the end of the day, we may tilt into a state of iron overload. So to avert this, the recommendation is that we should use the ideal body weight for such obese patient. And there is a formula for males, there is a formula for female. I've deliberately just put the formula for females only here since we deal with women. The ideal body weight in kilogram is equal to a factor 22 times the height of the woman in meters minus 10 centimeters. 10 centimeters in meters will be divided by 100, that's 0.1 is what you are minusing times a factor of 2. That will give you the woman's ideal body weight. For those who are dealing with men, in their private hospitals, you just remove the -10. It will just be 22 times height in meters times 2. So this is just an example that if we have a patient who weighed 108 kilograms and her height is 1.54 meters. Now, if we calculate her BMI, she's morbidly obese at 45.5 kilogram per meter squared, not kilogram, please, kilogram per meter squared. So ideal body weight, we won't want to use this weight of 108 kilograms for her. Instead, we'll now use this ideal body weight 22 times 1.54 minus 0.1 times 2. That gives us 63.4 kilograms. That's what we'll use to calculate the dose of our iron, intravenous iron. So now we come to the practicality of administering intravenous iron. General principle is 1, ensure you obtain consent before the procedure. Frankly speaking, most guidelines will favor a written informed consent, not verbal consent. Written informed consent, that's what it should be. Then you should anticipate possible emergency. Even though we tell you iron sucrose is safe, ferric carboxymaltose is safe, we have not told you that the risk of anaphylactic reaction is 0. We have only told you that the risk is minimal or close to being negligible. But we must still prepare because there might be one patient lurking around somewhere who is going to suffer from that life-threatening reaction, and we don't want to regret it. Secondly, you need good skill. Make sure somebody with a good skill performs the venipuncture because you don't want extravasation. If there are most of these iron preparation, they stain the skin and subcutaneous tissue badly and can give a very ugly, extensive appearance if the infusion is not well handled. Just like what you observe when patients are receiving chemotherapy intravenously and the patient might not be happy with you. Appropriate dosing is absolutely important because if you miscalculate and you tilt a patient to a state of iron overdose, that's another problem altogether. You don't want to go through all the challenges of now looking for chelating agents to control that. If there is a need for test dose, you can give, but unfortunately, we do not, or rather, fortunately, oftentimes you don't need a test dose before giving iron sucrose and ferric carboxymaltose. But for iron dextran, you need to give test dose. The regular monitoring of the patient to detect side effects, follow-up is also very important. So we come to the specifics now. Let's talk about the first one, anticipating emergency. You must have an emergency crash cart where you administer IV iron. That cart must include emergency drugs like adrenaline, ranitidine, hydrocortisone, promethazine, and beta-2 agonists like intravenous salbutamol or ipratropium, or rather not even intravenous salbutamol, but nebulized salbutamol will be preferred, and maybe ipratropium, all right? Then for fluids, you need plasma expanders. You should have them handy, like normal saline, isoplasma, or human cells. Oxygen must be available. You should have a nebulizer in such a place, and you should also have a good referral system in place. It is not when, because a patient might just start with mere coughing, and you just think it's a joke. You are managing, you observe urticaria, you give hydrocortisone, you think it's a child's play, and the next thing, bronchospasm just sets in, and then you're at a crossroad. So there must be a clear-cut referral pathway on ground, which was what we did in the Ivon trial. We made it clear to those at the primary healthcare facility, if there is any emergency, escalate to so place. We specify the referral center, alert the team so that we be on ground, so that issues like no bed space will not arrive. Then secondly, we also have an arrangement on ground for possible ambulance services. So these are things you should consider. And members of the team who will be administering this should have good skill in basic life support, if not advanced life support, so that if per chance condition gets worse and the patient arrests, they should be able in the minimum to conduct a cardiopulmonary resuscitation. Everyone who participated in the Ivon trial, both doctors and nurses, were all basic life support certified before we commenced the clinical trial. Now, the next step is for you to, if everything's in order, next step is for you to perform the venipuncture. Good skill is necessary. If you perform it wrongly, then the risk of extravasation is high. Ensure you use a wide bore cannula. By wide bore, usually, I know generally in medicine, when we say wide bore, we are expecting something of, let's say, up to 14G or at least 16G, meaning we are talking about the gray and white cannula. But what we have readily available oftentimes that is large and should be large enough for this purpose is the green cannula, which is 18G. And that was what we used in the Ivon trial. Now, you want to reassure the patient, even though you have counseled the patient in clinic. See, the anxiety is always there when a patient is about receiving something new. How much more a pregnant woman who knows she's carrying 2 lives? All right, so the anxiety is there. Is this thing going to harm me, especially when it's going straight into the bloodstream? So you need to reassure your patient. You need to calm your patient periodically. All right, watch your patient countenance and try to allay their anxieties. You need to wash your hand because this ideally must be a sterile procedure. The ideal thing is for us to wash our hand and then put on our sterile glove because you don't want to introduce infection or in the minimum even cause thrombophlebitis. You must identify a very good vein, ab initio. If you go for a tiny vein and you start battling, you will only end up pricking the patient unnecessarily. And if you're able to get the vessel the first time, it can easily rupture and extravasation can occur during the rapid infusion. So your best bet is to get a very large vein, even if it's the cubital vein, no problem. So that that's the brachial vein, no cubital vein, no problem, so that you can be sure that the risk of extravasation is less. Tourniquet, be mindful, don't apply tourniquet for too long. This is just a general tip for all IV administration. Then after sighting the cannula, do remember to flush before you commence the infusion. Flush with ordinary normal saline and watch for evidence of extravasation. Then appropriate dosing, that we have already exhausted when we talked about the calculation, but please ensure that even if somebody has, if the weight has been checked some time ago, you can reweight the patient to be sure of the weight and the height. All right, make sure your weighing skills are okay. Always make sure there is no zero error. Check for zero error before you weigh your patient. Then ensure your dosage is appropriately calculated. In fact, we recommend that you double check. In the Ivon trial, we ensure that people double check. If the doctor has calculated in clinic before and is passing the patient on to the nurse will recalculate again to be very sure that what the doctor has documented is appropriate before now calling the doctor to come and start the infusion after setting up the tray. So when you are withdrawing from the vials, you also want to minimize the risk of spillage, because if significant proportion spill, then you can rest assured you are not giving the patient appropriate dose if all you have to give is what is left. Then you should, when you are withdrawing, try to bring it a little towards eye level. That's the vial, to be sure there is no parallax error when you are withdrawing. Document the dosage clearly. Always good to document. Not just for medical reasons, even for ethical reasons, assuming something happens later and your activities are being probed or audited. Everything should be clearly spelled out. Yeah. So now for test dose, I've already told you don't need it for iron sucrose and ferric carboxymaltose. But for iron dextran, for instance, look at what the recommendation of the manufacturer is. But usually after injecting IV, you want to wait for minimum 5 minutes and you check the injection site, check the patient's vitals and ask questions to know if there is any infusion reaction. If there is any reaction at all, it's recommended you don't give the medication. But if there is none, then you can proceed with the total dose iron you want to give. Now, ensure that when you have to dilute these preparations in normal saline, try to constitute at the time you are about using so that you start using immediately. For ferric carboxymaltose, for instance, it becomes unstable once it is constituted. When it's not constituted, it's still stable. But once you dilute it, it becomes unstable, meaning you can't even guarantee the effectiveness anymore. Then when you are regulating the flow rate, make sure it's appropriately regulated because you don't want to give too fast. Now, regarding monitoring, how do you monitor the patient? You want to check her vital signs. For Ivon trial, we checked every 5 minutes. When we started the infusion, the first 2 minutes into the infusion, we checked vital signs. Then subsequently, at 5, 10, 15 minutes, we check vital sign. If there is, you want to check vital signs like pulse rate, blood pressure, respiratory rate, and oxygen saturation and temperature. These are very important because the patient might have tachycardia. That's a side effect, might have hypotension or hypertension. Might be tachypneic if anaphylaxis is setting in and may even start desaturating if there is bronchial spasm. Some may experience fever. So that's why all these 5 vital signs are important. Then one-on-one interaction with the patient is key. You have to ask her question. How are you, madam? Hope everything's going on well. Do you have any complaint? Please do not prompt the patient when you are asking questions. If not, the patient will think there is something wrong somewhere or there is something wrong you are doing and you are only waiting to see if a problem will arise. Let us speak freely, all right? Let her speak freely so that she can explain to you if she's having any adverse event and she can explain freely. In the Ivon trial, we observe our patients for 1 hour before allowing them home. So it's highly recommended you do that. Don't just let them go home at the end of infusion. Now, most patients will not have any issue during administration and even after administration, but a small proportion will have issues. And some of the adverse events they might experience, I've mentioned some earlier. I mentioned hypertension, hypotension. Gastrointestinal effects too can occur, even though they are intravenous. But the risk for gastrointestinal effect is far less compared to oral iron. Dizziness, fainting spells, lightheadedness, headache, flushing. Then for with the use of iron sucrose, some might have a change in their taste. This usually transient. After the infusion, they will get better. Then some might have fever, they might have chills, and some might have hypophosphatemia. But most times, most cases of hypophosphatemia in the literature are asymptomatic. That is not to say that symptoms might not occur. anaphylactic reaction, rare with iron sucrose and ferric carboxymaltose. That's not to say that they can occur. Now, of all these adverse events I've mentioned, the most dreaded is hypophosphatemia and anaphylactic reaction. And for that reason, I'm going to focus strictly on the management of these two. Now, for hypophosphatemia, the woman you may just notice that there is a loss of the muscle reflex, and the woman starts experiencing some weakness. Or she might complain to you that she's having some numbness, all right, often in the extremities, or like the hands, legs, all right. And if it becomes severe enough, she might even go into start having features of heart failure, or start complaining of outright muscle pain, not just weakness. She might have altered sensorium and might even convulse. How do we treat? You can treat through oral or intravenous route. One thing about phosphate replacement is that we have to be extremely careful. We have to be extremely careful because if you mistakenly give high dose intravenously, the risk of hyperphosphatemia is there, which is another problem again. Or she may go into hypophosphatemia, or she will develop hypocalcemia and start having tetany, because phosphate is known to bring about precipitation of calcium, or she might go into hypotension. Now, if the condition is mild, the symptoms are very mild, you might consider just prescribe phosphorus supplement for her to take home, and then you can continue monitoring. All right, you can take the blood to assess the level, put on phosphorus supplements, and then you monitor until she fully recovers. If the symptoms are severe, that's maybe not having altered sensorium and convulsion, of course, there may be need for intravenous one. For this, I will highly recommend that you involve the clinical pathologist, all right, for accurate dosing and proper monitoring so that you don't mistakenly give overdose. For those who are asymptomatic or maybe have very mild one, dietary replacement can also be offered. These foods listed here are known to contain high phosphate content. So you can give them health education, counseling on the kind of foods to introduce into their diet. Now we come to anaphylactic reactions. How do you recognize this? When a patient is having, let's say, difficulty in breathing, or you notice there is tachypnea, that's why you are checking respiratory rate. Or you notice the breathing is now beginning to sound noisy, or she's wheezing or even coughing, or she complains to you that she's now experiencing maybe difficulty in swallowing maybe her saliva, then you know there is a problem. Or maybe suddenly a patient you have been conversing with all along that has such a beautiful voice, suddenly is experiencing hoarseness of the voice, or she tells you outright that she's feeling this tightness in her throat, then know that there is an emergency at hand. You might actually even see her tongue swelling, all right? Or you might see a urticaria reaction on her skin. Now, this is an algorithm for the management of, we use this algorithm in the IVON trial. We actually prepared a chart of this, and we ensured that it was there in all the clinics so that the research team members can even make reference to it. Now, it depends on the severity of the hypersensitivity reaction. That will determine what you do. Let's take it first. If it's mild, she has just mild symptoms like itchiness, flushing, urticaria, maybe having the sensation of heat in the body, or just mild chest tightness, all right? And maybe mild hypertension. What do? The first thing is to stop the infusion. you want to observe the patient for at least 15 minutes after stopping it. You check the vital signs, you ask her questions about symptoms to know if they have resolved. If they have not resolved, assuming it's the nurse that is there, if it has not resolved, then a doctor should be called in who will do extensive examination, including vital signs check. If the doctor observes urticaria rash on the skin, then the doctor should give IV chlorpheniramine, that's ferritin, 10 milligrams, slowly. Now, if the patient feels better, all right, you can recommence the infusion, if not yet exhausted, but you administer slowly and monitor closely. All right. Now, assuming that after the, okay. So if the patient did not get better with the intravenous chlorpheniramine, then you might manage as for moderate hypersensitivity reaction. All right. If on recommencing that infusion, you observe that the reactions seem to be recurring, even at a much slower rate, then you might have to stop the medication infusion altogether, and then you observe the patient for a longer period. Everything you do for such patients should be clearly documented in between interventions so that you don't miss out information. If the hypersensitivity reaction is of moderate severity, what will you do? That's when we say moderate, maybe apart from those things she had as mild, I mentioned for mild reaction, you now notice obvious shortness of breath or the chest tightness worsen, or it's no longer elevated blood pressure, but hypotension. Then that becomes a more serious emergency compared to what it is for the mild case. You want to stop the infusion immediately. This is not a case for the nurse to start handling or to start trying anything, but to call the doctor immediately. You want to give IV ranitidine at a dose of 50 milligrams start slowly over 2 minutes. Then you give intravenous hydrocortisone, 200 milligrams start. And then you start normal saline. So then you observe the patient for at least 4 hours, document everything. If despite all this, the patient's condition is deteriorating, then you manage as for severe anaphylactic reaction, all right? When is it severe? If the patient has any of all the symptoms we have mentioned previously, and maybe in addition to that, if there is wheezing, anytime there is wheezing or stridor, it is severe, or you observe obvious edema of the face, it is severe, or if there is cyanosis, it's severe. You don't even need any other sign before treating as for severe reaction once you have this. So what do? You stop the reaction. You stop the infusion. You cannot handle a severe reaction alone. You call for help.
It's expensive now.
You must call for help. That's the first thing after stopping. Then you give adrenaline, 0.5 milligrams in 1,000 dilution. You give into the anterolateral aspect of the thigh, intramuscularly. After giving that, you give IV ranitidine, 50 milligrams start slowly over 2 minutes like you did for moderate. You give hydrocortisone, 200 milligrams start. You give, if there is obvious, if there is wheezing and stridor, of course, you may want to start nebulizing with salbutamol immediately. Then you also want to give normal saline. You commence oxygen by face mask, and of course, let everything be on ground for potential basic life support or advanced life support in case cardiopulmonary arrest occurs. If you do not have facility for intensive care, once you stabilize this patient, try to refer as fast as you can, because such a patient will need to be transferred to the ICU. So that's how you manage these severe reactions we are all afraid of. In conclusion, I've taken you through the history of intravenous iron therapies and explained to you the challenges associated with its administration and the benefits of the use of intravenous iron for pregnant women with iron deficiency, anemia, and anemia. I have taken you through the practical step. It's important for you to be very vigilant, monitor your patient closely so that you can promptly recognize and treat adverse events that occur. All said, this is not to put fear in you. I want to emphasize again that in the IVON trial, there was actually no reason to be afraid, and the clinical trial has actually improved our confidence that intravenous iron indeed is safe in pregnancy. Thank you. The floor is open for question and brainstorming now.